primary care is an innovative, alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever so relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Maryal Concepcion, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
Direct primary care is primary care as it is meant to be. Put in a more nerdy way, I believe it is the value-based advanced primary care model of the future, where incentives are fully aligned around a human relationship, an awesome experience for everyone involved, and optimizing health span. I'm Dr. Ben Aiken of Lantern Health, and this is my DPC story.
Dr. Ben Aiken is a family physician with a background in international studies and public health. He completed his schooling at UNC Chapel Hill before pursuing full-spectrum family medicine training at MAHEC in Asheville, North Carolina, where he served as chief resident. After joining the faculty to lead the development of a new clinic using a low-overhead, high-technology approach, he was brought on to lead the design and development of a direct primary care practice as part of Mission Health, a fully integrated health system in Western North Carolina. With the sale of Mission Health to HCA Healthcare, he transitioned the practice to be fully independent as Lantern Health, where he still practices alongside 7 other physicians at 2 clinic locations. Dr. Aiken is interested in and driven by the reemergence of primary care and societal wellness through clinic and system-level innovation and design. He serves as an advisor and previous VP of Health for Decent, a startup health insurance company bringing level-funded plans built around DPC to small businesses. He is board certified in lifestyle medicine and passionate about eating well and being active, having been a college tennis player and with a love for exploring the mountains, rivers, and woods in Western North Carolina and elsewhere, particularly alongside his wife and 2 kids in their collective community. Welcome to the podcast, Dr. Aiken.
Thanks so much for having me.
It's always a treat to talk with you. The last time we spoke in person was when we were in Washington, D.C., lobbying for direct primary care, which we will get into. But it was so refreshing to be independent doctors standing up for the model that we love. And I want to first focus on where that love of full scope family medicine came from. You have a very strong public health background. And one of the things that I really deeply tuned into was this idea that you really believe in a collective community. And so recently, at the time that we're recording this is Asian Pacific Islander Month, and I had submitted an article that was featured on Kevin MD talking about my culture in Sacramento in a Filipino family growing up in a collectivist society. And so it really speaks to me because for those people who are not aware, a collectivist society is one where everybody helps hold each other up. So the whole idea of a rising tide floats all boats, that's basically describing a collectivist society. So for you, what does collectivism and collective society mean to you based on your experience, not only in public health, but just being a doctor and a dad?
Yeah, it's a great question. I appreciate you speaking to it. I did public health school before I did medical school, and in some ways feel like I was a public health student that did med school on the side, whereas most of the time it's the other way around. And so the idea of thinking about public health, medical school trains you to basically treat people at an individual level, whereas public health school really trains you to think about treating people at a community level or at a system level. And so that type of thinking very much kind of shaped my experience in coming through medical school and still in my practice as a physician. And it is more oriented around the community than the individual. And so as I think about kind of collectivism in the primary care, to me, really feels like a big foundation of what we're doing is taking care of communities. We are part most of the time, if you're doing some degree of in-person care, I think especially, we're very much part of our communities. And so I don't think go into primary care not recognizing that you may run into people at the grocery store, you may see them out in the town like you are, and a lot of these folks share very intimate personal things with you, and you're there to care for them. And so I think it's hard not to, at least for me, it's certainly very hard not to think about the broader community as a whole. And yes, I need to make sure that they are healthy as individuals. But if we're able to do that well, then they are also then in a position to help support the collective community as well. So it's kind of that indirect benefit of, if you will. So that's how I think about it.
I love it. And I think it was in our Patreon portion of Dr. Angela Bymaster's interview that has aired previously, where we were talking about the change that she brought, or she is bringing rather, to her community in San Jose, California. She's in this, I believe it's like a 10 block by 10 block, very low income location. And with her DPC, I commented that it's interesting because with you guys having such a place for not only health to happen in the doctor's office, but also health to happen specifically for the youth in her area, where she has youth pastors and people who are really honing in on mentorship and positive role models for these young people who are in that radius. I made this comment that, like, it's interesting because the more you keep that up, I don't think that in the future, 10, 15 years down the road, when these kids go to college and become doctors or lawyers or whatever they wish to be, that 10 by 10 block is no longer going to be low income kids struggling to get ahead. And so I totally hear you when you talk about taking care of individuals matters, because the individuals are part of the society. And so let me ask you there, when you had these foundations in making systemic change, but also impacting the individual, how did that drive your passion for system level change in healthcare?
Yeah, I think I'm drawn to both, right? I wouldn't be a practicing family medicine physician if I didn't want to have that individual relationship and impact. But as shared before, really my thinking, my leaning, I guess, is towards the system level. And so, and I can't help myself, I guess I just put it that way. I think about things at a system level. I guess how that evolved as it relates to this is, it was very obvious to me very early in my training in a fee-for-service, individual focused primary care practices, not just family medicine, but really all the primary care practices that you rotate through, that there was just quite a bit of dysfunction. I mean, it was just like, wow, I can't believe I'm considering going into this. And I think most residency clinics or medical school clinics in primary care, particularly family medicine, you really see that. And if you don't, like, you just have your blinders on. And so immediately for me, my reaction was to take a step back and say, wait a second. We all know, and it's been pretty widely proven for years and years, that the foundation of any high functioning healthcare system in the world is robust primary care. And yet what I'm experiencing here in this individual capacity on a day-to-day level is not functioning well. That kind of the instinct was, let's take a step back and think about how this could function better, in essence, to reclaim its place as a proper foundation. And so that to me feels like where, that connection is, in the sense that this core function of the broader system, which is primary care and family medicine, in the status quo is not functioning well. It's actually functioning like really terribly, and no one's satisfied. Physicians aren't satisfied, patients aren't satisfied. And if we're thinking about things at a system level, there is that also represents an incredible opportunity for change.
Amen to that. So let me ask you there, when you were at this cusp of, wow, somebody has tasked me to create a direct primary care practice within a system, and then the Mission Health system that you were in was sold to HCA Healthcare, you did not just go along with the status quo and having these beliefs in collectivism and systemic change. You opened Lantern Health. I want to ask about that transition in particular, because it definitely is much easier financially for people, especially us who go to medical school, who most likely will have some kind of debt, to choose a different path rather than just going with the flow of the stream.
Yeah, that's really well said. I was one of those residency graduates in my first two roles. My first job was an employed position as a faculty member and launching a new practice for the residency program. My second job was an employed physician launching a direct primary care, which was, at least at that time, very, very atypical. And I received a fair bit of caution from various direct primary care providers as to kind of the authenticity of the ask from the health system. But ultimately, as I weighed the pluses and minuses of things, and I took a chance and felt like we were going to launch what felt like a pure direct primary care practice, really separate from the regular primary care of the system, and feel like we did that, which was good. And just to kind of speak to kind of how that went down a little bit, because I think folks might find it interesting. We branded the practice separately. We, in essence, kept it very hush hush amongst all of the primary care providers that were working for the system, because the concern was going to be everybody was going to want to do it. And they were going to come after me as a relatively young physician who was somewhat inexperienced and say, why the heck does this random guy get to do this when I've been slugging it out for 10 years or 15 years in this crappy system, and you're still just making me stay in this crappy system? So some interesting dynamics in that regard. So nonetheless, it was a good place for me to start. But as pressures have impact on big systems, this big system sold to one of the biggest systems in the country. And then basically, in essence, they were just going to close the practice. And they thought about it for a minute, but as most big systems, they weren't really willing to push the envelope from an innovation perspective. So I felt like I had a head start, and I'm still thankful for that medical from Mission Health in terms of supporting us and getting going, and had started to develop a bit of a reputation in our community. And so I was able to leverage that to basically try and kind of launch independently. I will say that there's a part of me that feels quite proud that as a single young family doctor, I was able to negotiate some things with 46, I think, $billion company that had as deep of a legal team as any probably in the country, and come out of that okay. And so I do feel some degree of pride in that. And also, I think, learn some good things from within the system that really shape how I think about, as you mentioned, kind of more system level change. So yes, at an individual single practice level, I think the amount of impact is tremendous. But how do we replicate that, whether it's us replicating it or helping other people to join in, so that we can become the standard form of primary care nationally? That's really what excites me.
And you have such a unique perspective, because as we go forward in American healthcare, and as we see everybody around us, patients, the government, everybody just like screaming, we need to change things. Like, physicians have been saying that for a while, patients have been saying that for a while, but now we're in this time where Department of Justice and Homeland Security and other people are getting riled up about our healthcare system to an extent that we haven't seen before, in my opinion. And with you having the view that you have because of this transition that you made, I think it's so I just draw attention to that, especially for the listeners, because as we talk about very hot topics, should we work with employers? Should we can large systems have DPC? You've definitely lived a different life than most people in this movement. So I think that everything that we're going to be talking about is manifesting from the things that you have seen. So I really appreciate you sharing your story and bringing your perspective to the table, especially as we fight to not recreate the fee-for-service system that we are trying to get away from so desperately. So with that, you talked about how you had created a separate name. You guys were sort of under the radar. Can you tell us about the creation of Lantern Health as a brand?
Yeah, I think we had an initial core team that basically was willing to kind of come with me to launch this new thing from before. And we all sat down together and really reflected on kind of what our ethos was and kind of what we wanted to represent. We were always oriented around the word health being in the name in place of other commonly used ones like medicine and other things, but just kind of oriented around health. And then really wanted to try and come up with a word that people sometimes would just use, even if they didn't use health. And we had a short list of things, and Lantern really emerged relatively quickly as something that felt like it was lighting a path, if you will. And similar to, I think, what people experience around, you have to check and see if these things have been utilized by other direct primary cares or other health entities in your community or in your region, and kind of make sure that it is available. And in this case, it was. And so we leaned in on that, and really kind of each instance of trying to figure out kind of what it would represent really continued to resonate. We've been very pleased with it so far.
Amazing. And your logo, for those people who have not seen it yet, is a circular logo that encompasses the words Lantern Health. And the logo itself is like an ombre with a yellow, definitely bringing that. I feel a sense of inspiration when I look at that, or inspiration or hope when I look at your logo, especially the colors. So, can you tell us about how you created the logo for Lantern Health?
Yeah, I engaged a local trusted designer that had a good reputation and whose materials that I had seen like really resonated as something that felt both modern but not harsh. And we very much wanted to kind of be approachable, but also clean and simple, so somewhat minimalistic, and work together in some different iterations. And we really, I think, when you think about a lantern, you kind of think of almost like a lamppost or somebody walking through the woods holding this lantern, and did a little tinkering with kind of an old school type lantern, but at the same time, that just didn't quite resonate from that crispness perspective, and felt like a circle, especially a yellow circle, really draws us to the idea of light, and felt like that was a good starting point. So that's how we came up with it.
I love it. And it just speaks to, as there are people working in the logo space, how do I create a logo? What kind of things could represent me? Whether they work with a branding and marketing specialist or they DIY it. I think that that is so nice to hear, because like you worked with the traditional, like the actual picture of a lantern, but you can also deliver that same message. And I feel that because you didn't use the lantern itself, it does have a more, and this goes to the copy on your website, but it does have a very, it leaves the person open to imagination rather than, oh, this is the lantern clinic. Like this is the place where you see the graphic. It's very clean. It's very futuristic. So I think that that bodes well with your goals for systemic change, especially what you're doing in your area. So let me ask there, in regards to copy, on the bottom of your website, you have, we illuminate the path toward a better and brighter future in healthcare. So this is a chicken or egg question, but I wanted to ask, when you guys were on this branding journey, did you have that slogan first, or did you have the name of your clinic first as you guys were getting quickly to Lantern Health?
The wording was there before. So Western North Carolina, for those that aren't familiar, has a strong history in certain types of craft and certain types of art, especially pottery. And there is a really kind of deep connection to craft as a result in the community. And so we historically, really, in thinking about our brand, had always, there's also a lot of craft breweries here. So there's craft in various different forms. But we've been really feel like we're in the craft of delivering primary care, if you will, and wanted this experience to feel most crafted, and in essence connecting with the roots of where we live and what matters to this community in regards to craft and art. We had come up with, in essence, kind of a, not necessarily, as we were thinking about mission, vision, values, which I think is a really like cool exercise for anybody that's assembling a team of people to deliver care to do, and actually do deeply, not just superficially, because it really allows you to orient around kind of a shared purpose. And we've used that more than I would have even imagined as kind of an early business owner in subsequent years. But as part of that, we actually had a roots statement, or kind of, some people will call it like, where do you come from, or what's your background? And in that roots statement, we had this wording. And so as we developed the Lantern brand, I think we may have added in "and brighter" in that sentence when we added Lantern as the brand, but the illuminating the path was there from the beginning and really fit nicely.
Wonderful. And just going along with this visual of a root statement, you also have on your homepage a description of Lantern Health, specifically grounded in a relationship between people, focused on an authentic experience, crafted to help you achieve your optimal health. So, with that intentionality of growing from this root statement, how did you guys come to that? Was it a continuous exercise, and mission, vision, and values to get you there? Or was that something that was crafted over time because of what feedback you were getting back from your patients as you grew?
Yeah, it's a good question. Now, we spent a lot of time on that. And I, again, would just kind of say that the experience that we've had subsequent is that, and I heard this from a fellow business owner, actually a chocolate maker in our community, of all things, about how much time they spent on their mission, vision, values, and how instrumental that was to creating a culture that they found to be really successful. And that just landed with me really, really well. So we spent really weeks with this. So it was team meetings and kind of tinkering and thinking about wording and where this was, and also just reflecting really in the early days, like what is it that we're trying to do and why is it that we believe so strongly in this model, and kind of what the value prop or kind of the distinguishing factors are. And so for us, the things that emerged are this kind of deeply human experience and relationship. Like we all love continuity, like we want long-term relationships. We want to leverage technology to make those relationships better, but at the foundational level, it's still this human thing of connecting with another human. And we wanted that to be part of what we were offering. The second component is really experience. So I think just the experience of being a doctor in this model is drastically different than the experience in traditional status quo fee-for-service models. The experience of being a patient here is also different. And in essence, I think one of the fun things about a membership-based model is that at the core, it's this financial model. But then you can think about what are the things that you're going to do, what's your flavor, what's that you're going to do in essence to basically make this experience as good as it could possibly be for the people that you're serving. So in essence, we sometimes think of ourselves as being in the hospitality business in some ways. And so at the same time, we really wanted that and still really want that to be authentic. Like I have intentionally like never learned a sales pitch. Yes, we take care of a lot of businesses, but I haven't written one down or studied it. And that's really intentional. Like we just want to be authentic in terms of who we are and trying to convey that, hey, we think we're doing this in a better way and we want you to be a part of it rather than kind of being overly calculated. So that's where that kind of came in as it relates to the experience. And then the final piece is just related to kind of this incentive alignment that's so powerful in direct primary care, which is like we win if people stay really healthy. And if people get really sick and they come see us every week, the model breaks. And what being like, there are so many different kind of variations of primary care modalities that are out there that I think are really potentially powerful. And I'm not a believer that one is the right path for everyone. And so an example of this is I have a board certification in lifestyle medicine, but we do not call ourselves a lifestyle medicine practice. Like we are a primary care practice. Do I think lifestyle medicine is really good primary care? Absolutely. And that being said, though, lifestyle medicine is probably not the best fit right now for all of my patients. Some, they thrive in it and we've had amazing outcomes. But at the same time, what somebody that comes to see me, their definition of optimal health or improving their health is really something that can be very personal to them and may be quite different than what I hope to get them to. And so we really kind of said that in the way that it's just kind of oriented toward this isn't really about us. We're hopefully bringing a lot to the table, but this is about you and helping you figure out what optimal means for you. And then using our guidance to try to get you there, whatever that may be, and kind of meeting you where you are. So perhaps a little bit rambly, but that's at least some of the intention that was put in behind that saying. And I feel like it's so far for us now quite a few years in has really kind of held the test of time and we stand by it.
And I think that will be so helpful for people who are even working on how do I explain DPC to myself, especially those doctors who are in the opening stages, planning stages of DPC, where they have not yet experienced what you speak of, but hearing, this is why I love everybody's story shared on this podcast. Everyone approaches how to describe DPC differently, depending on their community, depending on if they're known in their community, if they've had patients join them, if they're opening from zero, whatever the case may be. But so hearing the intentionality, I think, will help other people start thinking about, oh, like what Dr. Aiken said, I can speak to that. And these are my examples to speak to that. Could I craft my mission, vision, values from that? So, and then the other thing I wanted to say there too is when you talk about that it's just this whole experience of DPC is so different, especially for us as physicians. Like I remember I was texting you last night. I just did sutures for a 3-year-old who cut their chin open. And like, this is sort of warped because we're doctors and we do things like procedures, but it's like, for those of you who are doctors, you can understand what I'm trying to say here. Like, when you're like making a wedding cake for someone's wedding and they're so happy, like the bride and groom and the family are just like impressed by your cake. That's what I feel like when people talk positively about our practices. You get so excited and you're so proud and you're so like, did I ever feel like this in fee for service? I really don't know. But in DPC, the answer is absolutely yes. So again, just a challenge to those people who have not worked on mission, vision, values. These are words to think about for sure. Now,
Absolutely. That's so well said. I think one thought that just came to mind, it's not atypical that people say, hey, what surprises you the most about going into DPC? And I think there are various things, but one of the things that has surprised me is actually how positive the feedback has been. Like I just didn't, and it's not in some way, not trying to say we're doing something that's exceptional here, like or tooting our own horn at all. It is just that we're delivering care in a model that is so appreciated. And in comparison to where I was previously, I could never have imagined getting the positive feedback that we get currently. And now it feels relatively commonplace. Now I think we're well positioned because like the standard care is so dismal that we stand out. But I do feel like even long term that this type of feedback will come back, and that is it helps. I mean, there are absolutely hard days, and there are financial risks and all kinds of things that go into pulling off a DPC. So you have to be eyes wide open to that. But man, the good feedback sometimes that we get, to your point, is so affirming and really helps keep me going.
awesome. So let's take a step back in time because at one point you were branching off and making Lantern Health its own independent DPC practice in your area. So when you opened, did you have any patients who came over? Did you have any non-compete issues at the time because this was a separate entity compared to Mission?
Yeah, good question. We were able to keep most of our patients, and because I was going out to be independent, the non-compete that I was under was irrelevant. So if I had gone to try and open a DPC as part of another health system, then I would have had to move to Alaska or something. But yeah, since I was doing it independently, there was no threat. And I think that kind of how we position, like we were losing money at that point on behalf of the health system. And so the idea that they could kind of get rid of an entity that was losing money certainly helped kind of grease that discussion, if you will.
It's crazy, right? Because I mean, we're operating from totally separate systems where one is business oriented, profit oriented, not patient centered, and we are completely opposite. And then you have, oh, the primary care clinic loses money, blah, 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 because they don't generate referrals within our system because they take good care of their people. It's like, it's not like that. I mean, that is one way to look at healthcare. That is what has driven us into the situation we are in now. But it's so crazy to think that we have been so commoditized as a specialty, especially and I'm speaking to primary care here. And we are so viewed by larger health systems as
They use us as loss leaders. It's the term that I've heard.
okay.
I think just so people have this insight, like part of their interest in direct primary care was that it actually could be a financially like self-sustaining model. And we had built the model and the structure to take about 3 years to break even. So higher overhead input than most independent DPCs do when they're launching their own practice. So we had a very nice space. And at that point I was employed. And so I was being paid even if there weren't patients coming in. And that would in time would have been very appropriate. So but we had 3 years to break even, and it was about the 2 year mark when they decided to close the practice. And so, but it even amongst healthcare execs in the big system, kind of the default expectation is that primary care is going to lose money. And subsequent in the last maybe 4 years, really since being out of the system, I've probably had more than 10 now folks that are still inside the system, kind of executive types, say, hey, just would you be willing to talk? Because I saw that you did this as part of a system. And I was trained in my healthcare administration course that basically primary care is a loss leader and that's just the way it is. And if you want to do it, you're going to lose on primary, but you'll get the downstream referrals and all that specifics. And usually they say if you refer 2 knee surgeries and 1 cardiothoracic surgery, you've easily covered your loss per year. It's very detailed and down to a science. But hey, you know what? Actually, we're paying attention now because it seems like some big players are getting into the primary care space, and they wouldn't be getting into the primary care space if there wasn't a different way to do it. And so, can you tell us more about this different way? Now, I still haven't really seen a lot of systems start to dive in and do it, but I would expect in the next 5 to 10 years we'll see it more.
And it definitely is happening. I mean, even the term direct primary care is being used by big systems. There's one in Southern California, and it's when a patient it's interesting because when a patient sees direct primary care and they know like, oh, my aunt has that in Pocatello, they're gonna look for that. And then will it taint the reputation that DPC has as independent clinics? I don't know, but what I will say is that no matter what is happening, you stay steadfast and you continue to build your brand and deliver clinical medicine, and the way that you do it that nobody else can replicate. Just keep focusing on that in your community, because as we see and as we've seen with your practice, even within the employer space, your word of mouth has really continued to compound the growth of your practice. And one more thing I want to add there, just on this discussion of like the loss leaders, because that's a great term. I had not heard of that term before, but it totally is what it represents what I experienced in a corporation, and as an employed physician. But I thought it was also ironic that as soon as I quit, I kept hearing buzzes of, oh my gosh, that's a loss of $1 million at least to lose a primary care physician. It's, well, I wish you would have focused on that number instead of that we expect our primary care doctors to lose us money overall every single year.
Yeah. It's discouraging. I mean, I think really both at the hospital system level, but then also at a broader national level. And I don't know the exact numbers, but if you think of, again, being a system nerd, I think our overall spend for primary care is somewhere in the 6 to 7% range. And really, it should be at least double that if we are going to have primary care as a strong foundation. And so, and I think that kind of goes across the board. So, and that's going to take some work from us as physician leaders to really kind of keep hammering that message home so that people don't just say, hey, oh, you're just being kind of greedy doctors and trying to make more. No, actually, what we are trying to convey to you is that there needs to be a robust foundation of primary care to make our health system better. And we have to spend the dollars to get that done to really change the overall trajectory.
Amen. So let me ask you here now, going back to you opened your clinic, you had luckily patients that you were able to keep as you continued on in the independent version of Lantern Health. How did the initial year go for you in terms of you had a team, you had the brand, everything coming into being an independent practice, but that it's like you could have someone set up your DPC, but that does not a DPC make. In terms of you don't know the culture, you don't know how to do the workflows and all of the things that we learn as we do DPC in our communities. So can you talk to us about that first year? How was growth? How was working with the team? And was the word of mouth really picking up steam at that point?
Yeah, we technically launched Lantern on the 1st of February of 2020, having been in existence for about a year and almost 2 years at that point, kind of as the health system version. So less than 2 months after kind of launching on this new venture, COVID hit. And so it was a pretty wild year. I think for me personally, just getting comfortable with, for me, it was just delayed risk, right? Everybody who's launched a DPC practice has taken some degree of risk. My risk was kind of just 2 years after opening, where basically all of the burden was on me. So the financial risk was on me, the leadership pressure was there, and just kind of getting used to that weight and what that felt was definitely an adjustment. It took some time. And also there was pressure within less than 2 months to basically kind of pivot and navigate and respond to this pandemic that everybody was trying to figure out. At that point in time, we had maybe 15-ish, I don't know, maybe 10 or 12, 10 to 15 employer groups that had already enrolled and were part of our practice. And the majority of those were restaurants. And so those restaurants closed, majority of them just closed up shop completely for about 6 weeks, sometimes some up to 10 weeks. Asheville, for those that don't know where I live, where we are as a tourist town, if you will, like a lot of people come here for vacation and retirement. And so there's a lot of service industry, hotels, restaurants, those types of things. And so in terms of serving our employer community, restaurants are a big part of it. So in short, we had 100, I think at that time, 155 patients who lost their membership overnight. And as a result, for us, we in essence had the risk of losing that revenue. And as an earlier practice that was trying to build, that was not a small number for us. What surprised us is about half of those folks signed up themselves and just said, hey, listen, we see real value in this. And at least compared to expectation, that was more than we thought. The good news is, I think, in two capacities. One, we had about 60% of our care was already virtual pre-COVID, as I think probably is the case with a lot of DPCs where you just make that available. So we switched to virtual primarily, almost only, very easily, and that was not a problem. So we did see a dip in revenue with that, the closure of those businesses. Fortunately, a fair number of those businesses came back online by later in the year. And so we were able to overcome that loss. Outside of that, actually, we saw our growth trends they didn't change at all through the course of COVID. And in some capacity, we started to see that growth increase through the course of the year. So that felt really affirming that we were onto something and working towards getting to that break-even point based on the models that we were operating on. So that, and I guess we throw in, we did an EHR change too. So there was a fair bit in motion when we were part of the health system. We were on one of the legacy EHRs, Cerner, which many listeners may know. And so some kind of being liberated, if you will, we got to pick and moved on to one of the more DPC specific EHRs that was really fun and much more nimble and all the things. But for anybody who's been through a transition of trying to take records from one system to the next, it just is really almost virtually impossible to do in a streamlined, seamless way. So we did have quite a few things to navigate. I would not like to relive that first year, but I think perspective is important. And at least in that, our first year, some of my close friends who were still in the fee-for-service system were drowning because it's all built on volume. And so they were all highly envious. They were laying people off, trying to make ends meet. And we really, despite our dip from the employer loss, were really able to shelter that storm in a way that felt really affirming.
That's awesome. And I just go back to this root statement, and even just beyond the root statement, this idea of being grounded in a relationship. You were definitely grounded. It was the trial by fire relationship with your practice. And that first year, definitely, there was nothing like it. I totally agree with that. You have no idea what to expect. But I think that one of the biggest things to always remember is that there is a community, an insanely fast-growing community of direct primary care physicians all around you. I mean, you have 7 people, including yourself, who are physicians at your practice. So it's amazing, but definitely don't lose your bearings if you are like, oh my gosh, I'm drowning. I'm having a tough day. I'm having a great day. It just waxes and wanes. Totally normal. So let me ask you now, because mentioning how you have 7 physicians at your practice, you also have additional staff, and just to throw some roles and numbers out there. You have 2 locations. One is in downtown Asheville, and then the other one is your Asheville South location. And at your location where you're practicing, you have 5 MDs, including yourself, a CMA, an RN who is also a health coach, another health coach, a practice manager, practice coordinator, and a clinical coordinator. And then at your Asheville South location, you have 2 MDs, a practice manager, practice coordinator, a clinical coordinator, and a health coach. So I want to talk about how everybody came on board and how everybody is serving Lantern Health. So let's start with the physicians. 7 physicians, Ben. That is incredible. People are very frequently talking about, do I hire a physician? Can't find a physician. I got to go with a non-physician provider, or do a telemedicine option for this portion of my practice, whatever. How did you make Lantern Health so appealing, not only to patients clearly, but to physicians, to be able to grow to 7 physicians? And you just celebrated your 4th year anniversary into this.
Yeah, I think good fortune and some things just kind of coming together. So a couple things to speak through there. In short, for kind of every time we've had an opportunity to bring on another physician, I've had 2 to 3 that are seriously interested. And I've just felt really fortunate that that has been the case. And I've yet to post a job for a physician. So because I did my residency training in this community and was a faculty member for a year and kind of built some network here, I feel like that has benefited us tremendously in terms of kind of people proactively reaching out, and or if we are just kind of touching perhaps our social media circles or other things, that kind of when we do that, there seems to be a relatively strong response. To the physicians, kind of each subsequent physician that has joined, like I'm tremendously grateful because I feel like they have leaned in and kind of bought into this direct primary care movement. So then when we go out and we're looking to recruit an additional person, it's not just me telling this story, it's then 2 and now 3 and now 4 people. And we encourage folks that are thinking about this to get perspectives from all the different doctors that they so choose, because everybody's story is a little bit different in terms of what they like and they don't like and the reality of it. My experience has been so far as well, I'd say that there probably have been 2 or 3 kind of contact or close friends that have launched their own DPC that I would say I've leaned in more intentionally to try to support and help versus kind of just the one-off question that any number of us may contribute to on a Facebook group or something else like that, or at a conference or any of those things. And so when I have initial conversations with interested docs, like one of the first things I always talk about is, hey, listen, I just want to make sure that this is something that you can do on your own. And here are the pluses and minuses from my perspective of doing that. And at least in each instance where we've tried to bring on another physician, it's actually been there's been strikingly more interest in somebody who does not want to run the business but is really desiring to be able to practice primary care in a different way. And so in essence has looked at us as kind of this viable alternative to kind of leave the mothership, if you will. And so I have not tried to launch in a community where I don't have a presence or a network. I think that would be a very different thing. I think fortunately, as the movement grows, more and more physicians are paying attention. But I will say that based on my experience, my now bias is that there are probably more physicians out there that would rather join a practice than launch a practice. And I think those of us in DPC who like the business side and are comfortable doing the business side of practice, it represents a tremendous opportunity to bring folks into the direct primary care movement to allow them to deliver care in a different way without some of the headaches that we deal with on the business side that I don't mind. I enjoy that side of things and the thinking. And so that's been my experience so far in terms of bringing those folks on.
That's awesome. And I just lean on even our data in California from the CAFP. The data was showing that 86 to 90% of resident physicians after graduation go to employed models. And so it definitely speaks to there are people out there who are not necessarily interested in opening their own clinic. But as you said, there is not one model of healthcare that is perfect for every single physician. And one of those models that is absolutely an option now, because there's so many DPCs, is coming onto a DPC that's already open. So if you're out there listening and you're saying, that's me, go to lanterndpc.com and send Dr. Aiken an email. If you're not in North Carolina, send somebody in your community an email, but definitely ask, because like you've said, you haven't even posted a job. That's really, I laugh at that so much, because I think about the year and a half of recruitment that we went through to sign on at Fee for Service, and you're not even posting jobs. So, I have to tell that to our physician recruiter, who I still love, and she's a dear friend, but it's, golly, does that speak to the model, the power of the model, or what, right?
Yeah. And I think the other thing is, I think for those that are perhaps in DPC and are looking to recruit, be a part of your community, be a presence. You do a remarkable job of this through the podcast. But I think all of the family medicine residents that come to the residency here, they rotate with us. Like they come spend time here and they get to experience it. And so even if that's just buzz, that they were talking to somebody who was thinking about this and they said, oh, well, hey, did I spend some time at Lantern? And hey, it wasn't for me, but man, you should check it out. Or kind of just not in essence, kind of, yes, like we've extracted ourselves from the mothership and the big system, which really dominates in our community, but maintained a kind of collegial presence amongst the healthcare community so that kind of when that time comes, there is kind of at least our hope would be is that people have at least heard of us. And that is a better starting place to be than kind of saying, wait, what? I've never heard of direct primary care, and where do we begin? So anyway, I think it's a fun challenge, and we need more people in DPC. I mean, I think my hope is that the demand starts to outpace the supply, and then that kind of serves as a lever to really push more people to jump into it, because I sense that that could be coming.
And it's totally rooted in awareness. So this is where, again, I go back to Dr. Anand Mehta, totally in alignment with what we're both saying. Tell 5 people about DPC today. Even if it's like the random person who was asking you about your t-shirt with your clinic name at the grocery store, they will be a person who will tell another person, even if it's not for them, potentially. So with that, I want to ask about, as we're growing, clearly you have grown successfully maintaining support staff as well. So I mentioned all of the staff that you have on your team at Lantern, but I want to ask, especially when it comes to this, the roles of a practice coordinator versus a practice manager versus a clinical coordinator. Can you especially tell us the difference between those roles? And then how have you brought on the health coaches as well as the CMA that you have at Lantern?
Yeah, good questions. I would say from a staffing perspective, compared to some DPCs, are probably slightly higher overhead in terms of our staffing model. And it has been something we've really constantly iterated on from the beginning. So let me start there. In terms of how we saw this, or what we desired from the beginning, our desire was to have someone in a front desk reception type role. That is our practice coordinator role, because there we leverage that person to help with enrollments and some of our employer relations and those types of things, and really kind of oversee schedules and just really coordinate the experience that people are going to come in and experience at the practice. And really, they're the first line of contact. So when you talk about that hospitality piece, that role has really been critical for us, and something that we've had kind of really in launching a new practice last year. That was one of the kind of core foundational roles, in addition to the physician. The second core kind of foundational role has been originally what was kind of a nurse health coach role. So somebody that could help with nursing skills to help support the providers, from lab draws to vaccinations to procedures, et cetera, and triage. But then also, kind of from the beginning, we've wanted to have a health coach on the team, and we have. So in launching the new practice, like day one, we had a new health coach that just at that practice. The influence for me on the health coaching approach comes from 2 places. One, spending a lot of time internationally in my public health days, and really getting to experience the community health worker model that is used primarily outside of our country, but now increasingly in our own country, where in essence, lay people are trained up to be community health workers and really connect with people on the front lines. And countries that have wildly less money than we do have been able to achieve strikingly good outcomes as it relates to many different aspects of health and disease. And so that was influential and always kind of resonated. The second was I rotated as a resident with Iora Health. This was when they were in their very early days in Las Vegas. They had 2 clinics in Las Vegas, and they were serving casino workers. So this, for those that kind of pay attention to that space, was actually prior to Iora actually ever having a Medicare Advantage contract. And what they were doing at that time really was very much direct primary care for casino workers in Vegas. And it, for me, was a very much an aha moment. And their model, at least at that time, and I can't speak to what it is like now, as that has evolved to One Medical and now to Amazon, but is they had, I think, 3 at the time, 3 health coaches per doctor. And really, the health coach was the one driving this continuity relationship with the casino workers in Vegas and with their patients that would come to them. And I saw it in action. It worked really, really well. Patients responded really, really well to it. And so that also had a real influence on us. So to afford basically 3 health coaches per doctor, like out of the gate, is quite expensive. And so we thought we would start with a 1 health coach model and see how that landed. But it's been a really core kind of aspect of our offering, with our health coach being in just as much demand as the doctors on the team. So that is that role. We originally thought it would be blended. It would be like a nurse and a health coach doing both. What we found is that the nursing component, as we started to grow and bring on more physicians, became more and more in demand. So we still very much push against this idea that we need to have 2 to 3 CMAs per doctor so that we can turn rooms over faster than a hamster can turn a wheel. and have kind of limited that. So in essence, we have 5 doctors at our current downtown location where I'm based. Think of us as 3.5 doctors, because we have 3 part-timers. My clinical panel is relatively tight so that I can do the business stuff. And then we have 2 part-timers and 2 full-timers. And together we look like a little over 3 doctors. One great thing about DPC is like we have the flexibility to do that. Our argument, if you will, is, or premise is that to do continuity primary care well, you really need to be here at least a half day, 3 days a week, or in some capacity, kind of 3 days a week to be available to your patients, and also not to overburden other doctors that you may be sharing call with. And so we allow for part-time, basically to about 50% time for us is 1 full day and 2 half days a week. And that so far has worked out really, really well. So the point on it is, though, as it relates to staffing ratios, is that we have about, let's say, 3 doctors per model per location. And for that doctor, we now have 1 medical assistant. We have 1 triage nurse. They do blend their roles some, but we found that with the volume of messages and being so available that we have a triage component there on the front end to help with that. We have the person that coordinates up front, and then we have a health coach on the team. And it found that the demand for 1 health coach for about 3 doctors feels about right from a overall perspective. In preparation for launching a second location, and then in relation to me doing some side work for Decent, for a startup insurance company called Decent, building their plans around direct primary care, I brought a practice manager on to help with some of the business stuff. And she's been a tremendous asset to me personally, but also an asset to the team, especially as we've grown to a second location. And so that, I think that was just a role that I was doing until the point that I didn't have the time to do it. And it's, at least for me personally, it's been really important to maintain some clinical panel and presence. And so it's also important, I think, for everybody listening to be like aware that things take time on the business side, and doing those nights and weekends for the next 30 years is probably not a good idea for any of us. For the next couple, while you're getting started, is totally reasonable. But that was, as I was thinking through those processes, really bringing that person on. Yes, it was expensive. I made less. That's okay, because it's been so helpful. I see my kids more, all those things. So that's maybe more than people want to know, but that's kind of how we think about each location. And we're attempting to replicate that for the first time at the second location, where we have, in essence, 1.5 FTE doctors, 1 full-time doctor, 1 part-time doctor. We have a part-time health coach that will ramp up to a full-time health coach when the time comes. We have 1 CMA, and we have a practice coordinator.
It's incredible. And definitely just tossing this out there because, again, just like there's not one model of healthcare, DPC is not for everybody. There's ways of having staff, not having staff, and remembering always that, like you said, you don't want to have to be doing this until the day, like Dr. Julie Gunther in her Patreon episode said, you don't want to do this until you just like drop dead right in front of your patients. So it's do what's right for you. And there are mentors like yourself who are doing it like the way that you are doing it works very well, not only for your community, for your patients, but also for your employee patients, which we'll get to. So
right. Yeah, and I think just one thing just to mention, just so that people have this as a frame of reference and really try to be helpful in an open book, but because of our staffing models, our 2 basic expenses are our space and our staffing models. So in our spaces, we historically have not started small. We've started in spaces that we could grow to as a 3-provider practice so that we don't have to move. And that, in combination with a higher staff model, is higher overhead. So we still are operating on about a 2.5 year to break even model, which means more debt, and a longer term vision is like a requisite for that. And I've grown comfortable with that and feel like if I think 10 to 25 years out, it's not a big deal. But then I also I marvel and I'm very impressed by folks that seem to be able to break even within 3 to 6 months because they keep their overhead so low. And so there's really various paths to do this, but at least for us, 2 to 3 years feels okay. And so in certain business circles, that may not be encouraged, but at the same time, if you look at this again from a long-term trajectory, we're on a good path.
Next week, look forward to hearing more from Dr. Ben Aiken as we talk about his second location, how independent DPC doctors matter when it comes to DPC on Capitol Hill, and how Dr. Aiken and Lantern Health are bringing the model of DPC to local employers, large and small. If you are a passionate My DPC Story listener and have benefited from the stories and tips featured on the podcast, I hope you'll join our Patreon community. By becoming a patron, you'll unlock amazing perks like exclusive content. Basically, it's a whole nother podcast on DPC. Get access to special episodes only available to Patreon members, like practice updates from Dr. Lauren Petty, Dr. Julie Gunther, and more. Being a My DPC Story Patreon supports the work it takes to deliver reliable, quality content here each week. And it also helps expand the reach of the DPC movement, which could lead to a future physician hire at your practice. Head over to our Patreon page at patreon.com/MyDPCStoryFan and become a community member today. And if you are already a Patreon member, thank you so much for your continued support and being a vital part in the sustainability of this podcast. I hope to see many of you at the DPC Summit in Dallas in a couple of weeks. Come find me in the exhibitor hall where you can get some DPC swag. And as always, if you want to read more about DPC news on the daily, check out dpcnews.com. Until next week, this is Maryal Concepcion.